Welcome to APPA's 17th Town Hall on COVID-19. My name is Billy Zadig, APPA Standards and Codes Administrator. Allow me to review a couple of housekeeping items before we start. All attendees are in listen-only mode. We ask that you utilize the chat box for the question segment of this session. While we attempt to respond to all questions submitted, should we run out of time, responses will be posted to APPA's COVID-19 RAQ, Recently Asked Questions webpage. We also remind participants to ensure their speaker volume levels are set for their comfort. Our speaker is gathering us from across the continent, and as such, varying volumes will be present. Today's session will award professional continuing education credits as well as ISDs and AIA CLUs. For AIA certificates, please email me at Billie, B-I-L-L-I-E, @appa.org, along with your membership number if you have not done so in the past. Our webinar recording will be posted to APPA's website later this afternoon. Additionally, you will receive a follow-up email within 72 hours designating links to all recordings, presentation slides, as well as information on upcoming webinars and town halls. At this time, it's my pleasure to introduce Lander Medlin, APPA's Executive Vice President, your moderator for today. Lander, take it away.
Thank you, Billy. Welcome all attendees. We appreciate your engagement in these town hall meetings as we further explore the impact of COVID-19 on our facilities organizations and the education enterprise. Our town halls have occurred every Friday with a different target and focus. Yet we will pause for our delivery of the Virtual Facilities Summit, aka Annual Conference, this coming August 3 to 5, half days each, and give you time to sink into your fall reopening. We will resume August 21. However, if any questions or needs before then, please send them directly to me, Lander, at appa.org, Lander at appa.org, and I will research and respond. As always, thank you for joining the dialogue. Please post your questions at any time. That's what makes this a rich conversation and the special community we share. As schools determine their path to a fall reopening, you will need more detailed advice and guidance from a knowledgeable health professional who also resides in our industry and can help you consider additional ways to successfully orchestrate a safe and thoughtful reopening strategy. That's why we chose this topic today: testing and tracing, aerosolized particles, and the serology of the virus. Dr. Huey will share his knowledge, expertise, and professional advice of COVID-19 by increasing your understanding of the details around testing, tracing, and aerosolized particles for a safe and successful reopening strategy. So here's the format for today's town hall. I'll provide a brief introduction to set this week's context. In addition, today I'm adding highlights of the results from our latest survey. Then I will introduce our health professional panelist who will share his detailed content. We'll go with a Q&A from all of you, and I'll conclude with highlighting our resources and some closing remarks. The resurgence of coronavirus cases now tops 4 million. On cue, and as predicted, we recorded another horrendous milestone, over 1,100 American deaths for a second day in a row. Let's look back at the beginning point, March. We reached 1 million known cases in 99 days, then 2 million 43 days later, and 3 million 28 days after that, and now 4 million occurred in just 15 days. That is exponential growth and change, all adding significant, unbearable stress on the healthcare system. The positivity rate remains unfathomably high. The curve is spiking ever upward. No solace for herd immunity either, with no places near achieving the level of exposure to which the virus would stop spreading. So what do we do? Sounds simple, but I cannot emphasize enough. Everyone must follow the 3 W's. Wear a mask, wash your hands, watch your distance. Then box in the virus through strategic testing, rapid contact tracing, effective isolation, and support quarantine. This is the comprehensive response needed to get a handle on transmission and the rate of spread. There is some hopeful news for better diagnostic testing by year-end and potential vaccines in multiple stages. What is even more hopeful We are learning more about this virus and how to successfully treat it. That's great news. And economically speaking, new state unemployment claims rose last week to over 1.4 million amid new fears of a downturn. Plus, the additional unemployment benefits are set to expire next week. The United Nations referenced the disruption to education as unparalleled. Clearly, it's a historic and defining moment, bringing radical change to our entire system. Education's face-to-face reopening plans have gotten even more complicated with COVID's rapid spread to date and the steps necessary to mitigate and minimize hotspots and clusters on our campuses. There remains much preparation from facilities to ensure we follow the science and make decisions with enough time for effective implementation. This is indeed an untenable position for us. Our latest survey on testing, tracing, PPE, HVAC, and disinfectants paints the picture. Let's take a look at these infographic visuals to understand where we are and aren't. Here's what you told us. The first slide speaks to the issues you're having with testing and tracing, with most institutions very likely to administer viral virus testing with less expectation for antibody or antigen testing. Dr. Huey will inform us further on these methods. With respect to contact tracing, almost 80% will do so and 61% via a digital-based app. Interestingly, I would have expected more students as contact tracers, but you have identified 34% coming primarily from staff. But there is a high percentage mix of options as well at 46%. Now, this second slide is pretty straightforward, with a few more having PPE shortages of varying types of supplies. You can see that list. And I'll pop over to the right. Disinfectants systems are distributed fairly equally across misters, foggers, and sprayers, with UV and UVC least likely to be used to date. Finally, and to be expected with the new information on aerosolized particles, HVAC systems retrofits are a yes. However, with so many old existing building systems, it has gotten very complicated because so many are not compatible for MERV 13 plus upgrades. Plus the other category that's listed there at 17%, is represented primarily by a new system I was not aware of called bipolar ionization systems. You will find from the additional open-ended questions on our website now that the stated needs and challenges are very similar, such as managing fears, changing guidelines, handling HVAC systems, PPE acquisition, staffing resource shortages, consistent communications and messaging, and proper testing and tracing protocols, which Dr. Huey will be able to assist. The lessons learned were clearly around the importance of flexibility and adaptability, anchoring decisions in the science, communicating continuously and transparently, and treating your staff well. Thank you for participating and contributing, and please go to the website to view all of the details from your colleagues. Hence, our featured panelist will share his knowledge, expertise, and professional advice on the health and safety aspects of the coronavirus that you can apply to your cleaning and disinfection protocols and possibly HVAC systems strategies. You will quickly see there is no simple solution, no one solution, but rather some thoughtful advice and guidance. As COVID has reshaped our very way of life, the road to reopening will take leadership and collaboration, an aligned culture, and a measured approach to managing the health and science realities of the coronavirus. Let's get going. Michael Huey, MD, Associate Professor of Family and Preventive Medicine at the Emory University School of Medicine, and a member of the ACHA, American College Health Association, COVID-19 Task Force. He is also now the clinical consultant for Emory University's COVID-19 contact tracing program. Michael recently retired as the Assistant Vice President and Executive Director of Emory University Student Health Services. He is an ACHA past president and fellow, and the recipient of the 2019 ACHA Lifetime Achievement Award. In 2015-16, Michael was an Ebola clinical consultant with CDC National Center for Emerging and Zoonotic Infectious Diseases, and he deployed with the CDC Sierra Leone Ebola response as an infection prevention specialist in the summer of 2015. Dr. Huey, let's spend some time hearing your thoughts on the serology of the virus now versus what we knew back in March. Advice you have on testing and contact tracing, and the latest information you have on aerosolized particles. Dr. Huey?
Thank you, Lander. It really is a great pleasure for me to be back with APPA on this webinar. I was very fortunate to be a member of the panel on a webinar at the end of March, and 4 months have passed since then, and oh boy, things have changed. So we're going to be looking at many of the changes that have taken place over the course of the last 4 months. Let me start by saying that anyone who's run a department at a college or university knows that facilities management and campus services are critical to your department's success, but also to the institutional success. And that certainly has been the case over my 30 years at 3 different universities. So on behalf of all of the rest of us who are your colleagues at colleges and universities, we truly thank you for all that you do. Next slide. Got a number of goals on today's presentation. Some of them I'll probably meet better than others. We're going to look at the virology, the symptomatology, and the epidemiology of the SARS-CoV-2 virus. We're going to look at key points from the guidelines for reopening institutions of higher education in the COVID-19 era, which is an ACHA publication from early May. We're going to look at the timing, sensitivity, and specificity of testing. We're going to look at contact tracing and index case investigations. We're going to look at aerosolized particles, and I'm going to confess about the limitations of my knowledge in that area. So I'll say it right now. I'm hopeful that as we get to the Q&A part, there'll be many of you who might be willing to chime in with some of your advice on aerosolized particles, please. And finally, I'd like to look at some of the questions that we've received at ACHA since May. I think they'll be particularly illuminating on many of the areas that we'll be talking about today, including housing. And then we'll get on with Q&A sessions for all of you. Next slide. The American College Health Association, who I'm representing today, is celebrating its 100th anniversary this year. And like many national meetings and celebrations, our meeting and celebration in Chicago, which was the site of the founding of ACHA in 1920 during the great influenza pandemic, kind of ironic, that meeting was canceled. And as have many of your celebrations and meetings on your campuses, but we're still very proud of ACHA and its 100 years of strength. ACHA represents over 1,100 institutions and nearly 3,000 individual college health and wellness professionals. We engaged a COVID-19 task force in February, and I've been very pleased and blessed to be a member of that task force. Since we first started, we published many documents. We'll talk primarily about the reopening document today, but those documents can be found on our COVID-19 resource page at acha.org. Next slide. Let's start out by looking at the SARS-CoV-2 virus, its epidemiology, and the symptoms that it causes. Next slide. So here we go. We've got a lot to cover. So the good news is that these slides will be available to you on the APPA website. So I hope that you're not going to spend a lot of time furiously writing, because I'll be moving relatively quickly on a lot of this material, and including this review of virology and epidemiology, because you know this stuff and it informs your decision making. So you might pick up a few things, but most of this you do know. Coronaviruses are a large family of viruses. There's 7 strains. 4 of them cause colds. And then there's 3 strains that cause severe illness: SARS, MERS, the Middle Eastern Respiratory Syndrome, and SARS-CoV-2 that causes COVID-19. It's a novel virus. H1N1 was a novel virus. So you remember that. And we talk so much about vaccines right now, and that's because nobody is immune to this virus until we develop that immunity, either through infection or through vaccination. let's take a look at that picture over there on the right-hand side. And you've seen this picture a million times. And so those red things, the fuzzy red things sticking out, those are the antigens. Those are the proteins that interact with human cells or other hosts, non-human primates, for example, and even dogs and cats have gotten COVID-19. But those proteins attach like a key into a lock onto the surface of human receptor cells that are susceptible to the virus. And that's like all viruses, they have target cells. There's a capsule, that's the gray part that looks like a rug, probably is a rug actually now that I look at it. And that capsule or envelope surrounds the genetic material of the virus. So inside that rug is RNA. And human beings, our genetic material is DNA. RNA is the genetic material that connects to DNA and then makes proteins. And so what happens? So these viruses attach to the cell walls of human cells that have the right receptor, the right lock for this key, that red protein antigen, to unlock entry into that cells. And so it's a certain subset of our cells, and no surprise, it's those cells that are in the target organs, like the lungs, like the GI tract, like the heart. We're finding out about more target organs all the time, central nervous system. So, but an additional part of SARS-CoV-2 that has made it such an aggressive virus is that our own immune response to this virus can be stormy. And when we turn on our immune response and it starts attacking our own cells, and particularly the basement membranes that hold those cells together in the lungs, in the heart, in the central nervous system, then things start to break apart. And all of a sudden, you've got the storm that is SARS-CoV-2 and COVID-19 in the most susceptible members of our human species. And here's the final good news, because none of that was good news, is that that lipid envelope, that rug that you see around the virus, it is very susceptible to soap and water. Just like you have grease on your hands and you use soap and water and then you dunk your hands in the sink and there's all of that oily stuff floating on the surface, it's emulsified by soap. And so that's great news. Wash your hands. Next slide. Okay, so SARS-CoV-2 causes illnesses that range from very mild, including people with no reported symptoms, and that number, that percentage, appears to be on the rise. The more we find out about this virus, the more we realize that there's a lot of asymptomatic illness. You're familiar with the symptoms. Just to hit a couple of them: fever being the most commonly reported symptoms, shortness of breath, less common, but a key early symptom, because a lot of people get upper respiratory infections, but if you don't have asthma or COPD, chronic obstructive pulmonary disease, emphysema, chronic bronchitis, you're not usually getting short of breath when you have a cold. But when someone is short of breath right now, think SARS-CoV-2 until proven otherwise. Another unique but becoming increasingly recognized symptom is one of those central nervous symptoms, and that is loss of taste and smell. And it's not something you usually see with an upper respiratory infection, unless it's just that you're so clogged with mucus that you can't get air into your nose. But losing the sense of taste and smell is something that people who've had COVID-19 talk about a lot as just being so odd. If you get that symptom, think SARS-CoV-2. And finally, diarrhea and nausea. We used to have people coming to us saying, I'm sick, but it's just diarrhea, I'm a little nauseous, I've got some mild abdominal pain, and we say, well, clearly it's not COVID-19, it's a respiratory illness. But unfortunately, many, many people get GI symptoms prior to developing fever and lower respiratory tract. So when you see them, It's an early sign, but remember that, boy, there are a whole lot of illnesses, primarily viruses, that cause diarrhea and nausea. Next slide. Okay, this is an important slide, but it's busy. So I apologize for it, but I think we can learn a few things from it. So let's take a look. How long are people with COVID-19 contagious? What you see there in the middle of the slide is what all viruses do. They infect you. There's an incubation period where the virus is multiplying, and then there's a symptomatic period where you have signs and symptoms. But that would be great if nobody was contagious until they were symptomatic. But the infectious period for most viruses extend to prior to the onset of symptoms. And so you have a pre-symptomatic time when you're infectious, but you're not symptomatic. So remember this one. People who ultimately become symptomatic and you go, well, gosh, I guess this person has COVID-19, have a pre-symptomatic infectious period of 24 to 48 hours. So just keep that in mind. Remember that, because that's going to be the time during which people have pre-symptomatic spread. That's going to be what we use to set our dates when we're putting people into isolation and quarantine. So keep that in mind. Also, in this incubation period, there's going to be a 4-day mean for when people first get infected until they start to show symptoms. So that is the mean, but 98% of people who are infected will develop symptoms within 12 days. 12 days, remember 12 days, because that's a number that's going to come up as we start talking about quarantine. I might have gotten infected being exposed to this case. You're going to test me right away if you've got availability of testing to be sure I'm not already infected, but asymptomatic or pre-symptomatic myself. And then if I remain asymptomatic, you're going to test me at 12 days. Because if your tests, and you're lucky and your tests have a 24 to 48 hour turnaround, 98% chance that the test will be positive if I am in fact infected, then on day 14, you'll have my result and you can release me from quarantine. Next slide. So much has happened since the end of March. And when I spoke to you as part of the panel on March 25th, we had a whole different situation than we have right now. And very interestingly, in retrospect, if you look back just a week before that, on March 19th, on a website called medium.com, there was an article written by Tomas Puello, and it was called Coronavirus, the Hammer and the Dance. What the next 18 months can look like if our leaders buy us time. So what's the hammer? We start having an outbreak. And so you see the curve rising right there. The hammer is for 3 to 7 weeks, other than essential services and essential workers, you shut down society. And then as your numbers come down, so the curve goes back almost to zero, you start the dance. Until you have a vaccine or you have herd immunity from infection, which usually is about 70% of people immune, you got to open with the easy stuff, like letting controlled numbers of people into a supermarket at one time. We don't have to all have our food delivered as long as we wear masks and we go in a controlled flow. You watch that for 2 to 4 weeks. If numbers start going back up, you take a step backwards. If numbers aren't going up, you take a step forward. 1 step up, 1 step back, 1 step up, 2 steps back, 2 steps up, 1 step back. Sounds like a dance, right? So in general, in the United States, we were initially fairly good with the hammer. Admittedly, it was uneven. Some states were better than others. but we have not been very good, generally speaking, at the dance. We took too many steps forward, not enough steps back. We didn't respond quickly to changes in incidence of the disease, and now you see where we are. Next slide. Okay, when I spoke to you on March 25th, this is the Johns Hopkins website. I'm sure that most of you are probably familiar with it, and we were astonished at these numbers. There were 439,000 cases in the world. There had been 19,700 deaths. In the United States, we had 55,000 cases. And boy, that was scary. But I don't even know what the number of deaths were at that time because it was so few. It's not even on that list over on the right-hand side. On that list is Italy and Spain and China, not the United States. And so what has happened over the past 4 months? Next slide. Well, turns out we don't dance that well. We don't dance that well as a nation, and we don't dance that well as a planet. And Landers talked about this earlier. The growth is not linear, it's exponential. She talked about how long it took us to get to 1 million cases, then 2, then 3, then 4. Scary stuff, but look at those numbers. At the end of March, we had 632,000 deaths in the world. I'm sorry, let me go back. We had 19,000 deaths in the world. Now we have 632,000 deaths in the world 4 months later. We had 439,000 cases in the world. We now have 15.5 million cases. In the US, we had 55,000 cases. 2 nights ago, we reached the astonishing number of 4 million cases in the United States and 144,000 deaths. So if you look at that map that's there in the middle, it looks like an exact picture of the United States. Everything is in red, right? Well, except for Hawaii and Alaska up there. But you look at the continental United States, I know we've got a lot of hot spots right now. I spend my time in 2 of them, in Georgia and in Florida. But boy, oh boy, there's not a lot of safe places to go in the country because it's a red map now. Next slide. Okay, so who's at risk and who's at increased risk? These are things you know also. It's a novel risk, it's a novel virus, nobody's immune. Everybody's at risk. If you're in a place where ongoing community spread of COVID-19 has been reported, then you're going to be at risk, and the level of that risk is going to be dependent upon your location. Not a whole lot of protection out there, but there are better states to be in than others. Healthcare workers caring for patients with COVID-19 are at increased risk. Close contacts of people with COVID-19 are at increased risk. We'll talk about that soon. There was a time when we said travelers returning from affected locations. It's a moot point now, unfortunately. People over age 65, that's me. People with chronic medical conditions, there's a whole long list there, including lung disease, no surprise, cerebrovascular disease, cardiovascular disease, immunocompromising conditions or medications like cancer, and pregnancy and morbid obesity is on the list. If you feel ill and before you contact your healthcare provider, you want to take 5 minutes and say, what about these symptoms? Is it possible this could be COVID-19? CDC has a self-assessment tool. Emory Healthcare's got one, so there it is. So when you look later, you come back and look at these slides perhaps to try to get some details. Those are the links. Next slide. Okay, we're going to look at the key points from the American College Health Association guidelines for reopening institutions of higher education in the COVID-19 era. Next slide, but before we do that, I just want to tell you, oh, next slide, no, really. Yeah, thanks, Billy. CDC websites is full of so much fantastic information. I know a lot of you spend your time on there looking at guidance for institutions of higher education, cleaning guidelines for clinical spaces and non-clinical spaces. There's a plethora of information on there, and I know that CDC's taken a hit. It hasn't been a great time to be at the CDC with all of that back and forth that they've had to go through, but it's still the #1 most trusted US government agency, unless maybe you count Anthony Fauci, who is an institution now, and deservedly so, and ought to be in that garden of US heroes statue garden that is being planned in Washington, DC. Maybe we'll start a petition to get Anthony Fauci in there. Next slide. Okay, so on May 7th, ACHA published these guidelines. Many of you may have seen them. It was just a month after, barely more than a month after that last APPA webinar that I participated in. We were early with our guidelines. So our guidelines got out before CDC. Nobody was telling us we couldn't publish them. Before the NCAA, before the major medical societies, well, our members were clamoring for help. And so we really hit the accelerator. When you're first, you don't necessarily hit everything exactly. So if you look through these guidelines now, you'll say, ooh, I don't know if I agree with that. What about this? What about that? A lot of that information has come out since May 7th, but I still think that the majority of what was written is holding up. Next slide. So here are key concepts that are holding up in the guidelines. COVID-19 is going to peak differently in different states. The road to recovery is going to be long, probably 12 to 18 months or more. You're going to have to be gradual and phased in your resumption of activities. You got to base it on what your local public health conditions are and what is your institutional capacity to do, very importantly, widespread testing, contact tracing, isolation and quarantine of ill and exposed individuals on campus, and the ability to identify those people in the community that are connected to your campus. So this is all very important. You have to be able to do these things. If you're going to open up and have people working and learning and living on the campus, these steps need to be in place. Next slide. What are some other key concepts? Well, you got to, when you're planning, you got to prepare for the likelihood of a local rebound. And then you got to respond to those rebounds, and you got to do the dance. You got to be able to protect your most vulnerable populations, like your medically susceptible people, including elderly people, students of color who are at much higher risk due to health disparities, uninsured and underinsured people, homeless students, faculty, staff members. It's a moral and ethical obligation. I know that we're all sick of the term the new normal. It's just about as sick as we are of the term drinking from a fire hose. But there is a new normal. And so what is it? So this is one of the things I'll read to you. Meticulous adherence to public health practices, including hand hygiene, physical distancing, proper cough and sneeze etiquette, frequent disinfection of common and high traffic areas, symptom assessment, temperature checks, and face coverings in public. Next slide. Okay, so we're opening up America, hopefully at the right time, certainly not at the right time in many places. It's got to be a phased approach, and our campuses need to take a phased approach, and it needs to be based upon community and campus triggers to step forward, to step back, to go 2 steps forward, to go 1 step back. And finally, when we get to faculty, staff, and student immunity, either from infection, God help us, or from a vaccine, that will prove to be essential for our long-term planning and recovery as campus communities. Next slide. Okay, Lander wanted a section on testing because it affects each of us as individuals and it surely affects our institutions. But if you're a manager, there are some important concepts that testing centers on. And so it's going to be a good idea. And frankly, even if you're not a manager and you're listening right now, these things apply to you. And so the key to testing is timing, sensitivity, and specificity. Next slide. Okay, so what are the tests that are out there? There are 2 kinds of tests. The first type is the most important type to us right now. It's diagnostic tests. There are 2 kinds of diagnostic tests. The molecular nucleic acid tests, what are called RT-PCR tests, that test for the presence of viral RNA. Remember that genetic material, that nucleic acid. And then there are antigen tests that are rapid tests, and they test for those protein keys on the surface of the virus. So our nucleic acid tests, commonly that's what you're going to be using to diagnose your COVID-19 diseases, but ideally those results come back in 24 to 48 hours, but they might be longer. And so depending on the volume of tests that your lab that you are using is handling, it can be longer. Some of our employees at Emory have left the campus and gone to an urgent care center because they didn't want to wait for testing at the employee testing sites. And they got an RT-PCR nucleic acid test, great, but the results are going to take 10 days or 12 days. That doesn't help us. We can't manage a case if we don't know if they're positive or not. We got to contact trace, very importantly, in 24 to 48 hours after we know that that test is positive. So you got to be able to turn it around. And if you can't turn it around and you don't have any access to rapid turnaround, it's going to be very difficult for you to have faculty, staff, and students on your campus. What is sensitivity and specificity? Sensitivity is the likelihood that a negative test is a true negative. Specificity is the likelihood that a positive test is a true positive. So keep those in mind, and it's hard to do. Write it on the back of your name badge. I don't know, back there where you have what code pink is and what code black is. Write down sensitivity is that a negative is a true negative. Specificity, positive is a true positive. Stick it on the back. So what about these nucleic acid tests? The good ones, which is likely what your lab's going to be using, are close to 100% specific. And that means if it's positive, you have COVID-19. It's a true positive. And they are, most of them, approaching 98% sensitive. And that means that if your test is negative, it's 98% likely that it's a true negative. Okay, but these tests take time to come back. 24, 48 hours, 12 days. What about the rapid tests, which generally can be done and turn around in 20 minutes, 30 minutes? These tests, if you have one of the good ones, are close to 100% specific. So that's great. It's just like the PCR test. If it's positive, you have COVID-19. Here's the problem. We use these tests to tell us whether somebody is really negative, so we can release them, so they can say, okay, I don't have it. The rapid tests, even the very good ones, are running about 80% sensitive right now. So if you get a negative rapid antigen test, there's a 20% chance that it's a false negative. That's why we don't like to use them, But if we have to use them, boy, we're going to be a lot more confident if it's positive, unfortunately, but more confident than we would be if it's negative. 20% is a big window. It's 1 in 5 people. Next slide. Okay. What about antibody tests, these serologic tests that tell us if we're quote unquote immune? Do we have antibodies? You know, we can't make decisions based upon these tests right now because we don't know what level of antibody, what titer we need to have to say that we're immune. And we don't know how long they last, although it's starting to look like they're not going to last forever, folks. Some of the early studies are saying that they might last, like a vaccine might last 3 months or so. And that might get us out of this round of COVID-19, but it could mean that we have to have our COVID-19 shot every year when we get our flu shot. So we don't want to use these tests right now to make decisions about how we group people or employees. We don't want to use those tests to determine who returns to the workplace. We don't want to use them right now for screening, but the day may come when we use them for screening, when they get to be more reliable. And I have to tell you that right now, screening, whether it's by PCR or by antigen test or by antibody tests, CDC is not currently recommending routine mass screening of any population, including returning students. So if you're doing it, it's because you want every possible likelihood that you're making the right decision person by person, and you have the money to do it. And a lot of places don't. And so just know that right now CDC isn't saying that you have to be able to do routine mass screening. What you have to be able to do is immediate testing of people who are ill, identification of contacts of positives, isolation of the positives, quarantine of the close contacts. You have to be able to do those things, but you don't have to do routine mass screening. Next slide. Okay, very busy slide, and I'm not going to torture you by taking you through this, but it's a great slide. It's from the Journal of the American Medical Association, and so we're going to look at 2 things. One is the blue line. That's the blue line for nasopharyngeal swab testing by PCR, the one that's the most sensitive and most specific. When you do that test, it is likely to become positive during week 1 in 24 to 48 hours. Remember, we learned that, and I said, okay, you got to remember this. So here's why you needed to remember it. So look how high that is. Those numbers, that the titers on those nasopharyngeal swab PCR tests shoot through the roof during the week before, and when you get to 24 to 48 hours in week 1 of symptoms, then boom, likely to be positive. Okay, so there's the 2 days before is your pre-symptomatic. The 2 days after gets you to that mean of 4 days. All right, I probably confused you with that because I just confused myself, and that happens sometimes because I'm over age 65. All right, so what about antibody levels? There they are. There are the 2 antibodies, the IgM antibody, which is the immediate antibody that helps you fight infection and then falls off quickly, and the IgG antibodies, which goes up a little bit later, but lasts a long time, maybe, depending on the infection. And so those antibody levels are going to start to go up during week 2 and week 3, but they're not helping us right now. Next slide. Okay, quick sip. All right, what about testing priorities and capabilities? This guy is about to finish, I think probably finish, having his nasopharyngeal swab because he's giving you the nasopharyngeal swab look. And if you've had a nasopharyngeal swab for a PCR test, you know what I'm talking about. It's, oh, too far. Okay, that's the nasopharyngeal swab. So institutions that are going to open need to have the capability to offer diagnostic testings to students, faculty, and staff who need it. You want to prioritize that testing for people with symptoms. If you can't do it on campus, you have to be able to do it in the community, but you can't just say we can't test. And other testing activities should be consistent with the guidelines that you either get from your local experts, your local infectious disease people, or your public health authorities. Next slide. So you do the testing, but like I've said already, and so this is really important because I'm saying it again, it must be coupled with high intensity contact tracing, isolation of people with COVID-19, quarantine of close contacts. You want to aim for getting newly diagnosed people interviewed within 24 to 48 hours, and then tracing their contacts within 24 to 48 hours of knowing they have a positive test. Now, these tests are widely available in most places. Not all places, but most places, there's a lot of testing available, but you have to know what your capacity is. And there's regional and local variation. So you might be able to get a test, but the return time might not be uniform if the capacity of your local testing has been stretched to its limits. And that's when all of a sudden you start saying, I'm sorry, it's going to be 7 to 10 days. It's going to be 12 days before we get the test back. Not helpful. Next slide. Okay, well, Lander knows and I know that index case investigation and contact tracing is becoming a big deal on your campus and therefore a big deal in your life. 8 days ago, Emory brought me back from 2 years of retirement and flattered me and said, we really need you to provide clinical oversight to the contact tracing program. It'll probably be 2 to 3 months. We'll get some permanent people in then. It'll be half-time-ish. Okay, in week 1, understanding that anytime you take a new job, there's a learning curve. So I had a lot of stuff to learn about the IT systems and how all that worked. 45 hours for my half-time job. And I tried to be conservative in writing down how much time I was really putting on the job. I didn't want to put ACHA hours on Emory time. In the second week, day number 1, 11 hours. Day number 12, 12 hours. So if your people are doing contact tracing, if you're part of the contact tracing team because your university has mobilized smart people from a lot of different areas to beef up the contact tracing and index case investigation, God love you because you're working really hard. And if you're not part of contact tracing, God love you because you're working really hard. Next slide. Okay, so what do we need on our campus? I guess this is the third time I'm saying it. It means it's really, really, really important. Access to immediate testing for people with symptoms, contact tracing, identifying cases, quarantining close contacts, and managing cases. Managing cases of people that belong to you, whether they're faculty and staff and they live in the community, or they're students who live on the campus, or they're students who live off the campus. They need support, and that support means management of their isolation and quarantine. If they live on campus, they have to have a place on campus or off campus for them to be housed. Psychological support, because boy, when you tell someone your test is positive, get ready, because it's a big blow. Support for their basic needs like food and clothing and ongoing and bedding, ongoing monitoring while they're isolated. So that's what you need in terms of containment and surveillance. Next slide. Okay, you got to be able to track data because you use that data for decision making. So you're going to be looking at COVID-19 symptoms. You're going to be looking at influenza-like symptoms when, God help us, we have influenza and COVID-19 at the same time. And if you've got just widespread availability of testing, you might be doing some testing of groups of students, maybe from the sewage that's coming out of your residence halls, okay? And when the testing is reliable and accurate, you may be doing serologic antibody testing as you start to say, okay, we know now what level means that a person is immune. Finally, you got to have large-scale delivery of COVID-19 vaccines when they become available, and it's a novel virus. Everybody should be vaccinated except those who have a medical contraindication to the vaccine. We don't know what those are yet, but we will. There'll be some things that will say, okay, if you have this, it's going to interact with the vaccine. Okay, so don't put a sign on your quarantine areas or your isolation areas that says COVID-19 quarantine area, because that's a whole lot of violations. That's a HIPAA-FERPA violation. It's outing a lot of individuals. It's scaring everybody who might have rooms or houses right adjacent to those places or apartments. And so you're better off probably just doing the second part of the sign, which is authorized personnel only. Anyway, that's some advice. Next slide. Okay, I'm going to take a quick drink. And then I'm going to give you a quick overview of quarantine and isolation. What's the difference? You know this. It's probably burned into your mind by now. So very quickly, quarantine is people who are exposed but are well. Isolation is people that are infected. And self-observation and self-monitoring is for people that have high-risk conditions or are exposed, but maybe not exposed to the degree that they meet the criterion for quarantine. And I'm not sure that this is on the upcoming slide, so let me just tell you, the criterion for quarantine, the big criterion from CDC is exposure of less than 6 feet for 15 minutes or more during the actively infective phase of the case's illness. So your local, territorial, and tribal or state health department, that's who makes the decisions about how you're going to manage isolation and quarantine, for who and when. But CDC, which gives us general guidance about quarantine and isolation, and that's what we go look at. And I love the CDC. I really do. I worked for them once. But it's your local, territorial, tribal, or state health department that makes decisions about quarantine and isolation. Next slide. Okay, so we're not going to beat this into the ground because it's busy, but it's really good. So if you go back and you look at the slide set, look at this slide, it's number 28. This is about how you do case investigation. You identify a positive test and you put it into a database, and then it gets triaged and assigned to a case investigator, and they interview the patient and get all kinds of information about who might be exposed. And the patient identifies their contacts. If possible, it's great to know who the contacts are in advance. So many of our colleges and universities are asking us to identify our 10 or 12 most common contacts in our daily on-campus life now, before we get infected. And I'm not saying you're going to get infected, but before you have symptoms, you want to know who your contacts are. And then if you are identified as having the disease, then you look back at that list and you say, well, I have 12 people down here, but over those 48 hours, only 3 of them did I have that 6-foot face-to-face. And unfortunately, it doesn't matter whether you're wearing a mask as far as CDC is concerned, unless it's an N95 mask and you're in a healthcare situation in full PPE. But if you're in one of the cloth masks that we wear or the surgical masks, it's better not to say, well, I had a mask on, so we were face-to-face for 2 hours, but I had a mask on, because we know. So remember that your case investigators are very often, maybe most of the time even, not medical people. They're just really smart people who've been really well trained. Next slide. Okay, who gets out of isolation? So I'm sick with COVID-19. I've been diagnosed and I am recovering in a non-hospital setting, and I'm in a situation where the health department and the health authorities and the infectious disease people on the campus says I don't have to be tested to get out of isolation. So there's two different ways to get out of isolation. There's testing and there's not testing. Well, gosh, one of the things that we say all the time is that everything is changing, and I know it's frustrating, but as experts learn more things, they make sure that that's holding up, and then they change recommendations. So on Monday, after I had already started these slides, I had to go back on Monday and change this slide because it was 3 days, 72 hours with no fever. It's now 24 hours with no fever without the use of medicine that reduces your fever, and your other symptoms have improved, and at least 10 days have passed since your symptoms first appeared. So cdc.gov, coronavirus, do that, look up contact tracing, and you can see release from isolation. So here's what you're thinking. Wait a minute, I thought it was 14 days. I thought you told me that quarantine was 14 days. Not fair, I'm not even sick. The person who was sick, the person who exposed me, got out on day 10, and I'm in for 4 days after they got out. What's up with that? Hold that thought. Next slide. Okay. What are some of the other criteria for letting somebody out? And your institution may be using a test-based strategy, even for non-healthcare personnel, where they're saying if we've got an employee and they are positive for COVID-19, we do want testing. But there are non-test-based strategies. So if the person never developed symptoms, they were asymptomatic through the whole time, but they had a positive test, then they are isolated and have all the other precautions, but you can discontinue those at 10 days after the date of their first positive PCR test. Now, you may want to do a test-based strategy, particularly for people that are severely immunocompromised or for people with a severe illness. Maybe they can't come out at 10 days if they're severely immunocompromised or severely ill. Maybe they need to go 20 days. You really want consultation with infectious disease experts and with your local state and health department if you've got people that kind of fall out of the rubric of your testing. So it's going to depend on test availability. It's going to depend on turnaround of test times. It's going to depend on the local conditions on the ground. That's it. Next slide. Okay, what about all this contact tracing? Important to know that this isn't new. Didn't come up with the discovery of COVID-19. It's a fundamental tool that's been used to reduce the spread of communicable diseases for decades. And it's been used for STIs, it's used for sexually transmitted illnesses, it's used for TB, used for measles. So you set up contact tracing to try to reduce the spread by identifying people who have been contacts and were contacts long enough to be classified as a close contact who could have been exposed and is at risk. So your public health agency and others may be designated to do this. So on college campuses, particularly with the overwhelming burden now on the public health agencies, you think H1N1 was bad in a public health agency, oh my God. So they may have delegated this to your campus, to your health center. If you're a big campus and you have a health sciences center, maybe to your college health center. But contact tracing may be based on your campus. Some of you may be contact tracers. Next slide. Okay, but whoever does it, they have to be trained. They have to be expertly trained. And when you're a contact tracer, you're going to do in-depth interviews. You're going to determine when the case was infectious. You're going to figure out all the people and activities and locations during that infectious time for the index case person. And then you're going to contact those exposed people and begin a 14-day quarantine. Next slide. Okay, this is a big slide, and if you're going to come back and look at it. But it's important. It's got a whole bunch of stuff on it about how we do our work. It says CDC on the bottom, which means it's authoritative. But let's just kind of word our way through it. So next slide. Okay, in most places, if you're not an essential healthcare worker and you have access to testing, when you decide to put somebody in quarantine, you want an initial test as quickly as possible after their exposure. A PCR test is ideal because it's maximally sensitive and it's maximally specific. That helps you determine who is already infected but not symptomatic. And if you get that test back and you say, oh my gosh, Joan, you have COVID-19, but you're not symptomatic, now Joan becomes an index case, and you have to contact trace Joan's close contacts, okay? The second test, if you're doing a two-test strategy for quarantine, as I said earlier, usually done on day 12, remember day 12, because 98% of asymptomatic individuals will be positive by day 12 if they're infected. It is 98%. Last week at Emory, we had a medical student who tested positive on day 13. Okay, so it's not perfect, but if you do it on day 12, what you're trying to do is get almost everybody and then get them diagnosed or not diagnosed by day 14 and get them out. So that decision to release a contact from quarantine needs to be made at the local level, either by the health department or by who the health department has delegated to make that decision, maybe somebody on your campus, a health person. And then it needs to be communicated directly to the contact with educational materials in their primary language. Next slide. Okay, Lander said talk about aerosolized proteins, and oh my gosh. Okay, Lander, I'll talk about aerosolized proteins, but I don't really know anything about aerosolized proteins, so I started studying aerosolized proteins, and oh boy. Next slide. So here's the question. Is aerosolization a game changer? We've all talked about small droplets for 4 months, and those small droplets get coughed or sneezed or breathed, and they travel 2 meters or less, which is 6 feet in England and the United States and Australia. And they fall to the ground in a few seconds or onto those surfaces that you clean in a few seconds, except it looks like when they don't. So some of those small droplets evaporate in that droplet zone into smaller aerosolized particles, nuclei type particles, even though they're not cells so much. Yeah, they are, but they're fluid with cells in it. And that theoretically gets carried in air currents and into ventilation systems for minutes to hours. So is it a game changer? Next slide. Well, this happens sometimes. Sometimes an article is written and sent for review to be published where the material is a game changer potentially, and so the decision is made to release them early. So this article, which is not going to be published in the CDC Emerging Infectious Diseases Journal until September, was released at the end of June, early July. Why? Because what it showed was in multiple labs, they took the SARS-CoV-2 virus and they took the SARS virus and they took the MERS virus and they aerosolized them. Now, again, this is in a lab. It's not outside. It's not in your residence hall room, but it was in a lab. But what they found was that the dynamic aerosol efficiency of those viruses surpassed, of that SARS-CoV-2 virus, surpassed SARS, and it surpassed the Middle East respiratory virus. And it appears in that lab that they retained infectivity and the integrity of the viron, that whole thing, the little red things and the rug and the nucleic acid in the middle, that RNA, it retained the integrity of that for up to 16 hours in respiratory sized aerosols. So they submitted it in June and they published it in advance. Okay, next slide. So is aerosolization a game changer? Yes, almost certainly. It's a game changer. And gosh, you know, things are changing, and all these months we talk droplets, 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 and 6 feet, and that stuff is still really important. And this stuff is in lab settings, but you've got those droplets which are larger than 5 microns and go less than 6 feet. And you've got the aerosols, which are less than 5 microns and go longer than 6 feet, okay? So what about these super spreader events, like those choirs you heard about, or the bars, many of them in communities around our college campuses? We have all of a sudden there's 30 people in a bar and a bunch of them were football players, or you know, all these things in the news. Those super spreader events, particularly things like a choir where people are forcing air out of their lungs as hard as they possibly can, are probably connected to droplets, yes, but also aerosolized particles. Next slide. So what approach should you take to air filtration? I don't know, because I don't have any expertise in this area. I didn't know what ASHRAE was until last night, when Lander sent me an email that said, but what about the ASHRAE guidelines? And I said, Lander, we need to talk on the phone right now. Okay, so I've never heard of MERV 13 or MERV 14 or MERV more than 14. I don't know how much HEPA filters cost, particularly really, really big ones. And so I looked through the ASHRAE position document on infectious aerosols, and I would say to you that you should look through it too, and probably most of you have if you're in those kind of decision-making positions, and that those evidence level A recommendations by people that know what MERV 13 and HEPA filters are definitely worth looking at. I know that's not very helpful. Next slide. What else? Well, here's what else. Theodore Roosevelt said, you do what you can with what you have where you are, okay? So maybe you can't do all these things. Maybe your buildings were built in 1760. I attended the University of Edinburgh for a year when I was an undergraduate in Scotland. The building was built in 1650. I don't think we were fitting those with HEPA filters, right? So what can you do? What can anybody do? If you're in facilities management, you reduce your densities to the best of your ability in your living and learning spaces. You've spent a lot of time on that, and it's important. You increase ventilation, but boy, if you're not going to dilute indoor air with fresh outdoor air, if it's hot or it's humid or it's cold. And ASHRAE says, don't turn off your HVAC systems, please, where people live and learn. Sounds like good advice. Filter your air if you can. Use the best filters that you can. That sounds like good advice to me. But also maximize your non-HVAC measures, because we got to break that chain of transmission. Talked a lot about viruses so far. This is my area. Use effective surface and space cleaning. Isolate and quarantine into appropriate spaces, and vaccinate when you get it. Okay, I hope you're not disappointed. That's the aerosolization part. Here's what I'm hoping. Those of you out there that know about HVAC and aerosolization, please chime in. Hopefully I won't run us out of time. Chime in. Next slide. Okay, when all else fails, go to the CDC. At all times in institutions of higher learning, what does CDC tell us to do? Encourage everybody to protect their personal health by using masks, always whenever possible, except when they're alone, and eating and drinking and hand hygiene. Post your signs all over, not just on buildings, but on social media and everywhere, that people look about fever, cough, shortness of breath, and the other symptoms. Make sure people stay home when they're sick. Clean your frequently touched surfaces. Limit events and meetings and classes that require close contact if they are not mandatory for the purpose. Stay up to date on developments in your community and nationally. Create an emergency plan for a possible outbreak or re-outbreak on your campus, and I know you have, and figure out who the people are in your community that are at higher risk and plan accordingly for those people, including protecting their privacy. Next slide. Okay, I know you have questions, but I would like to speed through these a little bit because we've had so many questions since we published the May 7th guidelines. And okay, so I'm going to out myself here. I wrote the housing, dining, athletics, and rec services and communications guidelines. There were 7 of us who wrote the guidelines. Those were my sections. And so turns out that I overlap a lot of your stuff. And that's why Lander and ACHA thought that I might be a good match back in March. And now I'm a good match now, I guess, except I don't know anything about HVAC. Next slide. Okay, what are you going to do with your employees working at high-risk positions? It's a difficult question. You're going to take them on a case-by-case basis. You're going to protect their privacy. You'll get your general counsel and senior leadership involved if you have to, particularly if you're making blanket decisions. You're going to assess your job assignments by virtue of their potential exposure to COVID-19. That's big for you and it's big for everybody, particularly those in management roles. And then you're going to start looking at your high-risk employees. You're going to invite them to disclose to you, which they're not required to do. And if they do, you have to tell them that you will protect their privacy unless they give you permission or it is an overwhelming directive from the public health department, like if they get sick. And then you're going to consider each high-risk employee and their duties. And if they can do their duties remotely, you're going to think about them doing remotely. If they're lower risk duties, you're going to think about those for them. And if you can't do those things, you may need to think about excusing certain individuals, which is not a good thing when your workforce is overstressed, and I know that. Next slide. Okay, ton of the questions that I've received are about housing, because in most of our places, students are living with 2 or more people in a room, and they're from different parts of the country and the world, and somebody's from Texas or Florida or Georgia, and they're in there with somebody from Montana. So what are you going to do? Okay, well, if you don't have single occupancy rooms, then you can't have single occupancy rooms unless you reduce density. So if you're not reducing density, or maybe even if you are, you might be starting early. You might be PCR testing people who come onto campus and live on campus. You might pair up negatives. You're going to retest for symptoms, absolutely. You might pair up PCR negative students who are from the same regions of the country or the world. And let's face it, that wrecks one of the best things about going to college, which is having a roommate that's different from you. But you know, it's an extraordinary time. You may want to pair up someone who's already recovered from COVID-19, understanding that they may not be immune indefinitely. You may say, hey, if one of you gets quarantined due to an exposure, the 2 of you, the 3 of you, the whatever of you are a family unit. So we're going to quarantine you like a family. Next slide. And those are just, if you can, if it's right for you, these are just suggestions because I don't have any answers here. All right. Hey, I was in a residence hall at UCLA when I was an undergraduate. That was a huge thing shared by 20 people at a time. It was a group bathroom. What if we don't have any single occupancy bathrooms, or we have limited occupancy bathrooms? Well, you might think of cohorting to high usage times. You might do physical distancing, blocking off showers, toilets, sinks. You probably looked at all these things. You may have to think of additional custodial staff, which could be hard because it would be great to assign people to specific bathrooms so they could go in between cohorts. But what if you had to excuse a bunch of high-risk people? I don't have an easy answer for you there. Next slide. What about high-risk people? If you're going to have high-risk people be in the first wave, you want to try to use the single rooms for them without outing them if you can, because you hate for everybody to be immediately identified as you have a single room, then you have this or that. And what are the legal implications? Lots of legal implications. What if you have them sign a release? Is that enough? No, probably not. They usually don't hold up in court. Kind of dumps it all back on them too. Is that really the right thing to do? Next slide. What about discrimination, confidentiality, morbid obesity? Are you going to tell morbidly obese people they can't be in your residence halls? It's not an easy time right now, let's face it. Next slide. We're moving through these fast because we're at 1:16 and I don't want to use up all your time for questions. You want to identify your isolation and quarantine spaces. Some of them may be on campus for you. Some of them may be in motels, off campus. Some of them, maybe you can't identify that many. You're going to have to model how many of them you're going to use based upon the number of people who are infected by a single person. That's called the R0, R0. Talk to your sister institutions. You may say we're going to quarantine or we're going to isolate in place. You're going to have to put a lot of things in place if you do that. And there's some public relations aspects to that with students and parents for sure. Next slide. Boy, I hate to move through this fast. And I will tell you that it's not a great area of expertise for me, but we all know that there are health disparities and marginalized populations. And I didn't want to do a talk with 50+ slides and not say something about it because we have to think about people that have health disparities and how are we going to do something to help that. Well, here's the thing. Next slide. ACHA is just about to publish a article on health disparities, and these are a few of the things that are in it. And these concerns apply to faculty, staff, and students. And if you're in one of these groups, if you're a person of color, it is no surprise to you that there's outrage about health disparities for people of color in COVID-19, because that's always how it's been. And you're afraid, and I'm afraid, and gosh, I hope we're all afraid that everybody's talking about this right now because racism is a pandemic too. But once this is over, once we've got COVID-19 under control, it's going to fall out of the news cycle, and the disparities are not going to be center stage anymore. And that ought to worry us. So colleges and universities got to take the lead on this. Boy, we haven't been perfect. Let's face it, we haven't been perfect about societal change, but we can be, and we need to do better. Next slide. You know about the CDC and infection control guidelines about workspaces and cleaning rooms after an ill person. A lot of it's about ventilating the space. And there are lots of guidelines available out there. So go to cdc.gov. And next slide. Mental health well-being is so important during a pandemic, and I'm going to rush through it. And let's face it, there are a lot of focus. I've had a lot of focus on the physical signs and symptoms and clinical course of COVID-19 today, but maybe they don't even touch the emotional and social and financial disruption that are taking place in people's lives. And it's a trajectory of fear and stress and anxiety in ourselves and our co-workers. Those stressors are magnified in your people on the front line and in healthcare people. Those people that have hands-on activity and are in essential services or in support of essential services. So you gotta make things available to your faculty, staff, and students during this time that supports their mental well-being. Next slide. Lot of ideas about this. CDC's got things, and there's other websites like the UC Berkeley Student Health website's got some great stuff on managing fear and anxiety during COVID-19. If you look at these slides, you'll find these things. Next slide. And finally, we've got to keep our workforce safe. And so you're going to want to do those things. You're going to want to educate. You're going to want to use virtual meetings whenever you can. You're going to do everything in your power to have the right PPE and cleaning and disinfectant products. You're going to refigure your workspace about physical spacing. If you can, you're going to stagger shifts and return to work. You're going to have people checking their temperature and symptoms, begging them to stay home if they're sick, looking at your medically vulnerable, looking at people over age 65. You're going to do all these things because we got to keep our workforce safe, got to keep each other safe. Next slide. COVID-19 is a rapidly evolving situation. APPA and ACHA, we're going to give you the updated information you need, but keep looking other places and look at the CDC and look at your local territorial, tribal, or state health department and ask them for their advice and guidance. Next slide. ACHA has a COVID-19 research page for campuses at acha.org. Next slide. Lander, we have 9 minutes. I apologize for question and answers. And thank you so much for inviting me back.
Absolutely. And I will promise to folks, although we will not get through a number, you have lots of questions, and that's a good thing. I will work with Dr. Huey and ACHA to get responses. Dr. Huey, is that fair?
Absolutely.
Okay, great. And so some of them I do want to touch. It said, can you contract COVID after you have had it and recovered?
Yes, so there's the problem. There are some cases of that, and we don't 100% know if they are people that recovered and their antibodies didn't develop, or they fell off and they got infected again. Because remember I said, we don't think the antibodies are going to last very long, unfortunately. Okay. Or whether they had COVID, they got better, and then they got sick again. So the answer is, we're afraid the answer to that is yes. It's not going to be common. Hopefully we can get us through this first round and get a vaccine. And then if we have to do the vaccine every year, we'll do it every year. Okay. Do you have thoughts on pool testing? Boy, I think pool testing is wonderful if we can do it. I will tell you that the FDA has approved a couple of pool testing tests now. And so here's the thing. If you do not have widespread availability, but you want to test large groups of people, you want to test athletes, you want to test people that live in this residence hall, you want to test stool specimens coming out through the sewer system. You take all their tests and you throw them into one vial, and then you test them. And if it's negative, then all 10 of those people or all 20 of those people are negative, and off they go. If it's positive, then you have to do them one at a time. But since most of them are going to be negative, pooled testing is a good idea, but it's got to be with a product that has been approved for pool testing. Okay, very good. Well, that leads me nicely to the mention about wastewater testing. Would you recommend it for dorms? Is that the perfect place? Sure, if you have the capabilities. Now, okay, so that's the surveillance thing that we were talking about, okay? Yeah. So, if you're going to want to keep track of what's happening, if maybe you're going to be using that kind of thing as an indicator on your dashboard to decide, hey, do we have to change something we're doing because our titers of virus in the wastewater out of Sproul Hall has gone up 100%. Okay, so that's what it's for. It's for surveillance testing, and if you can do it, that may be great. But it takes some sophistication, I know, and maybe that's not going to be one of the things on your dashboard. Maybe your dashboard is going to have things like, and forgive me for this, if a student dies, we're going to close for a while. Okay, yeah. Maybe that's on your dashboard, but you can't get it together, and maybe you don't have to get it together to be testing wastewater.
Okay, because it is expensive. I've seen that, but on a per basis, depending on the institutional size, it could be a very good tool. Okay.
Well, I'll give you a tip, which is, I'm sorry, Lander. University of South Carolina looks like they're going to do it. So if you wanted to talk to somebody, and they'll probably kill me now, because 150 of you are going to call them tomorrow. So
no, I haven't.
I'm sorry, University of South Carolina, but I've been told
not just them. It's going to be University of Arizona is doing this. It looks like University of Arkansas, Fayetteville. We have a number of institutions that are leaning into this. So I think we'll have, I'll do sort of a call to find out.
Water it down, yeah. And that, no pun intended. Oh my God, water it down. Okay.
Yes. Okay. So if they're unable to buy test kits, viral or antigen, do you have any recommendations?
The antigen tests are the tests that you can do at point of care. And so unless you have a CLIA laboratory that can do moderate complexity tests or high complexity tests, you're not going to be doing RT-PCRs. So the antibody tests, you can do them, they're rapid. And so you buy a bunch of these Sophia machines, let's say, and you're running the tests and you're giving results in 20 minutes, and you have a bunch of them, and they're not cheap and they're not necessarily easy to get. They're trying to make them, as many of them as they can, but you do that. But remember that the sensitivity is 80%. And so with the sensitivity at 80%, you could have a false negative. So there you go.
Okay.
So if you can do it, great, but you got to know what the limitations are of the testing.
Okay, very good. And so I want to hit you with sort of a final question, given our time, and then you and I will do some stuff offline, which will be actually pretty easy. But how do you suggest smaller institutions address testing and contact tracing, because they're looking for options to proactively test other than using the health department resources? They don't have dorms. They're usually commuter schools, no research, no clinic, no medical staff. What are your thoughts on that?
Yeah, well, first of all, you have to be talking very closely with your local, state, tribal, or territorial health department, because they're the ones responsible for contact tracing, not you. Now, if you've got the resources, you may say, oh, look, we're the University of Arizona. We can do our own contact tracing on students, faculty, and staff, okay? And they may say, thank God you can do that. But maybe you can't do that because you're a small school. So you don't have the people to do that. You have to have your health people concentrating on those who are sick. So you want to be in very close contact with them to know that they can handle what happens. If all your students live locally, that's different than maybe you're a small school, but you're bringing 5,000 people from out of this little tiny Midwestern community onto your campus. You have to know that the local health department can handle that for contact tracing. Otherwise, you can't bring in more people than they can handle. So you got to work in very close cooperation. And one of the things about being a small school is you look at these large schools and you say, wow, the student health director must have a whole lot of responsibilities. Well, the truth is there's 19 infectious disease world experts, and there is a school of public health, and there's an emergency response group, but you're on this little tiny campus and you're the student health nurse practitioner or RN. None of those people are on the campus. So the people really with the big responsibilities across a wide spectrum are the people on the small campuses. And I think we should always keep that in mind. I mean, I was on a small campus once, with 3,000 students. And boy, you got a whole lot more things in your portfolio than when I was on the University of Florida campus with 50,000 students. A whole bunch of people to help me there.
That's excellent. And so, Michael Viola, I do have, I think, a solution for these spray bottles that you asked about. If you send me an email, I'll reach out to you at lander@appa.org. Also, Andrew Gutberley, I may be saying that wrong, and David Richard Webb provided some information in the question box on HVAC and modeling for densities and on checking codes for bathroom fixtures. So we will get that back out to people as well. And I do have some additional information on it. And Dr. Huey, I want to thank you so much for taking the time to do such great work for us. We preferred that you do what you did because I know I can get some other answers to questions from you. It's just super important. So thank you. Thank you.
It's been a great pleasure as before. Thanks, Lander.
Thanks so much, Dr. Huey. So I urge you to register now for our facilities, virtual facilities summit that occurs August 3 to 5. We do have a summer series. We have a continued call for images, a slide on other available resources, and that survey and all of the details of it are now on the website, and your colleagues have really given you some great information and detailed responses. We want you to save the date for our return to town halls the latter part of August. And then I'll close out paraphrasing the remarks from Lester Holt from NBC's Nightly News. He said, and I will say my way, we are losing the battle. I've shared statistics on infections, hospitalizations, deaths, and hotspots. Hats off to the medical workers, researchers, you said that, Dr. Huey, frontline workers, and neighborhood heroes. They were all doing their part. What about the rest of us? Yes, the science is evolving. We are just 7 months into this nightmare. But we have been given the low-tech tools that current science shows can save lives and give struggling businesses a fighting chance. Denial has left us in a state of calamity, yet a solution is sitting right there staring us down. No one will save us from ourselves. Let's muster the courage, sheer resolve to meet the moment. Remember, we are in this together, and together we will be the only way we find our way out of this. Good day and have a great weekend. We hope to see you at the Virtual Facilities Summit. Thank you so much, everyone. Goodbye.